多分質問出ないんで。
Ladies and gentlemen,
ですね。
thank you very much for attending the APASL 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the session. MAFLD2, the prognostic event for MAFLD, CVD, or extrahepatic cancer, chaired by Dr. Hirokazu Takahashi, Japan, Dr. Jun Inoue, Japan, Dr. Han Che-Lin, Taiwan.
Hello, everybody. Thank you so much for joining this session. This session is very important field because MAFLD or MASLD or NAFLD are very closely related to CVD disease and extrahepatic cancers as well. So today's speakers are very well experienced and or are very professional clinician in this field. So I'd like to introduce the first presenter, Dr. Norio Akuta. Shortly, I'd like to introduce his CV. So he is now a fellow of Tranmon Hospital. He was graduated Gifu University in 2004. And he had a lot of research experiences. And he's now a board member of JS, Japanese Study of Hepatology, and he's joining a lot of associate study group and associations. Okay, so Dr. Akuta, could you start your presentation?
Thank you very much, Professor Takahashi. Today's topic, treatment strategy of MAFLD with a view to suppression of cardiovascular diseases and liver-related events. Sure is shown. This slide shows the incidence rate of HCC in 9,959 patients with SLD diagnosed by ultrasonography at General Health Check of Tranmon Hospital, according to levels of ethanol intake. For example, ALD 0.21% per year, MET-ALD 0.11% per year, and MAFLD 0.05% per year. So ethanol intake affected hepatocarcinogenesis in patients with SLD. The HCC rates of MAFLD are not high rates. Background, ASLD practice guidance 2023 indicated that the most common cause of death in patients with MAFLD was related to cardiovascular diseases, shortly CVDs. Liver-related mortality was reported to be the second or third cause of death, and cancer-related mortality was among top 3 causes of death. In Asia, the incidence rates of these events still remain unclear. So we retrospectively investigated the incidence of 3 complications in patients with biopsy-proven MAFLD for median follow-up of 6.0 years. The incidence rate of 3 complications in 552 Japanese patients with biopsy-proven MAFLD at Tranmon Hospital. Number 1, CVDs, 1.04% per year. And number 2, malignancies, except for liver cancer, 0.83% per year. And number 3, liver-related events, 0.30% per year. So the incidence rates of CVDs are higher than those of malignancies or liver-related events, respectively. Incidence of malignancies except for liver cancer in MAFLD at Tranmon Hospital. Number 1, colorectal cancer, 25% of all malignancies. Number 2, lung cancer, 16%. And number 3, pancreatic cancer, 13%. So colorectal cancer indicated the highest rates as previously reported. age-appropriate cancer screening and general health check should be performed. This slide shows flowchart of treatment in MAFLD, the Japanese MAFLD NASH Guidelines 2020, Joint Committee of the Japanese Society of Gastroenterology and the Japanese Society of Hepatology. Now, step 1 recommended treatment, body weight reduction by diet and exercise, recommended. And step 2 suggested treatment, pharmacological treatment for complications, including type 2 diabetes mellitus, dyslipidemia, and hypertension. Step 1 recommended treatment, body weight reduction by diet and exercise. Hospitalization program for improvement purpose for SLD in Toranomon Hospital. This program, hospital stay 6 days from Monday to Saturday. From 1st June 2021, hospitalization program for improvement purpose for SLD in Toranomon Hospital was started. Now, 900 patients with SLD hospitalized or scheduled to hospitalize. Hospitalization program based on multidisciplinary approach, exercise, aerobic exercise, intensity of 4 to 5 metabolic equivalents, shortly METs, for 30 minutes daily, and resistance exercise, intensity of 4 to 5 METs for 20 minutes daily were performed under the guidance of physiotherapists. Next diet, a diet of 30 kilocalories multiplied by the ideal body weight, nutritional ratios, protein to fat to carbohydrate, 15 to 25 to 60% was consumed daily under the guidance of nutritionists. This slide shows trend of diet and exercise treatment for SLD. SLD practice guidance 2018, 6 years ago, indicated daily reduction by 500 to 1000 kilocalories and body weight loss 7 to 10% recommended. However, in SLD new guidance 2023 last year, these descriptions disappeared because there are many non-obese MAFLD patients in Asia, including Japan. Recent report indicated that body weight reduction 3 to 5% is adequate for non-obese MAFLD in Asia, including Japan. New SLD guidance last year emphasized the importance of personalized exercise, sustainability, and benefits regardless of body weight loss. Subject, treatment efficacy at 6 months after hospitalization were investigated. 186 hospitalized cases with SLD diagnosed by abdominal ultrasonography. This study included 82 cases of MAFLD. Result, liver function test at 6 months compared to baseline. We performed propensity score matched analysis, including gender, age, smoking, the presence of type 2 diabetes mellitus, and dyslipidemia. Result, AST, LT, gamma GTP improvement. The decreased rates of hospital group were significantly higher than those of non-hospital group. Next, glucose metabolism at 6 months compared to baseline. Unfortunately, fasting plasma glucose, hemoglobin A1C, no difference. The decreased rates of hospital group were not different from those of the non-hospital group. Next, lipid metabolism at 6 months compared to baseline. Unfortunately, total cholesterol, triglyceride, HDL, and LDL cholesterol, no difference. The decreased rates of the hospital group were not different from those of the non-hospital group. Next, body weight and body mass index at 6 months compared to baseline. Body weight, body mass index improvement. The decreased rates of the hospital group were significantly higher than those of the non-hospital group. So personalized diet and exercise program for SLD, improved liver function tests and body weight. This slide shows CVD risk score at 6 months compared to baseline. SUITA score is one of CVD risk score in Japan. So this program also improved CVD risk score at 6 months compared to baseline. Case presentation, one case who achieved decreases of each parameters after repeated hospitalization. This patient, first hospitalization on 6 days performed, gamma GTP body weight reduced. However, LT increased. So 3 months later, second hospitalization performed. So each parameters after repeated hospitalization decreased. So this case suggested that repeated hospitalizations were effective and might help to sustain diet and exercise treatment. Long-term treatment efficacy at 2 years was investigated according to the regularity of hospitalization. So regular and repeated hospitalizations every 6 months indicated the 4 times of the numbers of hospitalization, and irregular hospitalizations showed the 1 to 3 times. So long-term treatment efficacy at 2 years was evaluated. Result, liver function test at 2 years compared to baseline according to the regularity of hospitalization. We performed propensity score matched analysis, including gender, age, body mass index, smoking, the presence of type 2 diabetes mellitus, and dyslipidemia. Result, SDLT improvement. So the decrease rates in regular and repeated hospitalizations every 6 months were significantly higher than those of irregular hospitalizations. So the present study indicated long-term favorable efficacy of personalized diet and exercise program for SLD. We identified pretreatment factors associated with a decrease of 3% or more in hemoglobin A1C levels. Multivariate analysis identifies the etiology of MAFLD as one of the predictors of decreased rates of hemoglobin A1C levels. So the present findings highlight the importance of anti-diabetes drugs in addition to diet and exercise treatment for MAFLD. Next flowchart of treatment in MAFLD. Step 2, suggested treatment. Pharmacological treatment for complications, including type 2 diabetes mellitus, dyslipidemia, and hypertension. For example, type 2 diabetes mellitus, thyroxine, GLP-1 receptor agonist, and SGLT2 inhibitor suggested. Impacts of GLP-1 receptor agonist and SGLT2 inhibitor for cardiovascular diseases in patients with type 2 diabetes mellitus. This study primary endpoint, death from cardiovascular diseases, non-fatal myocardial infarction, and non-fatal stroke, 3-point major adverse cardiovascular events, shortly 3-point MACE. So GLP-1 receptor agonist and SGLT2 inhibitor are expected to improve prognosis of type 2 diabetes mellitus complicated by MAFLD, according to the reduction of 3-point MACE. Previous report indicated a placebo-controlled trial of GLP-1 receptor agonist in MAFLD. Subcutaneous semaglutide, 72 weeks double-blind phase 2 trial performed. New England Journal of Medicine reported primary endpoint, resolution of MASH with no worsening of fibrosis, and the secondary endpoint, improvement of at least one fibrosis stage with no worsening of MASH. Primary endpoint, significant difference. However, secondary endpoint, no difference. So GLP-1 receptor agonist achieved resolution of MASH with no worsening of fibrosis as primary endpoint. Now, phase 3 randomized control trial ongoing. GLP-1 receptor agonist is expected to improve the pathology of MAFLD. Histological impact at 5 years after the start of SGLT2 inhibitor were retrospectively investigated in MAFLD complicated by type 2 diabetes mellitus at Toronto Hospital. 6 cases were introduced SGLT2 inhibitor and underwent serial liver biopsy. So this is the primary endpoint. Histological improvement was defined as decrease in MAFLD activity score of 1 point or more without worsening in fibrosis stage compared to baseline. 2 patients received the additional treatment of GLP-1 receptor agonist after the point of 3 years and evaluated as histological worsening. Case presentation, this case, one good case. Histological findings of one improved case at the time of 5 years after the start of SGLT2 inhibitor. Pretreatment steatosis, 80% of all hepatocytes, very high rate. However, 24 weeks later after the start of treatment, steatosis 30% decrease. And 3 years, 5 years, steatosis 20% decrease and maintain. Fibrosis stage, pretreatment, stage 4 cirrhosis, 24 weeks later after the start of treatment, stage 3 decrease. And 3 years, 5 years, stage 3 decrease and maintain. So one case with long-term favorable histological effects. Next case, not good case. Histological findings of one improved case by addition of GLP-1 receptor agonist at the time of 3 years after the start of SGLT2 inhibitor. Pretreatment steatosis 30% of all hepatocytes. 24 weeks later after the start of treatment, steatosis 5% decrease. However, 3 years later, steatosis 50% reworsening. So we added GLP-1 receptor agonist from this point. So 5 years later, steatosis 5% decrease improvement. So addition of GLP-1 receptor agonist on SGLT2 inhibitor is expected as one of treatment options to SGLT2 inhibitor resistant case. Result, histological findings at the time of 5 years after the start of SGLT2 inhibitor in MAFLD complicated by type 2 diabetes mellitus. Fibrosis improvement, 33% at 5 years after the start of treatment compared to baseline, low rate. However, activity improvement, 50% at 5 years, high rate. Furthermore, histological improvement, 50% at 5 years after the start of treatment compared to baseline, high rate. So SGLT2 inhibitor for MAFLD shows the long-term favorable histological effects. Furthermore, none developed 3-point MACE during 5 years. Summary, GLP-1 receptor agonist and SGLT2 inhibitor might improve prognosis for MAFLD complicated by type 2 diabetes mellitus according to the reduction of complications. For example, type 2 diabetes mellitus suppression, CVD suppression, and liver cancer cirrhosis, maybe suppression. So diabetes therapeutics are expected to improve the pathology of MAFLD, including CVDs and liver-related events. Last slide, conclusion number 1. In Japanese patients with MAFLD, the incidence rates of CVDs were higher than those of malignancies or liver-related events, respectively. Number 2, colorectal cancer indicated the highest rates of malignancies except for liver cancer in Japan. These findings suggested the importance of age-appropriate cancer screening and general health check. And last, number 3, personalized medicine with diet and exercise and diabetes therapeutics are expected to improve the pathology of MAFLD, including the suppression of CVDs and liver-related events. Thank you for your attention.
Thank you so much for your presentation, Dr. Kuta. Anybody have a question? Okay, so can I have a question from me? So, the first cohort study is the patients or health checkups examinee. So, which the patient?
General health cohort.
General
in
health
mouse.
cohort.
はい
So, okay.
Okay.
So, they have a risk of colorectal cancer.
Yeah.
So, do you have any screening or surveillance for
Mm.
such people or your plan in future?
Okay. Age appropriate cancer screening is very important. For example, patients of 65 years old or more should undergo general health check, including endoscopy due to high rates of extrahepatic malignancies.
Okay, that's very important. And any question? Okay. So in the study of hospitalization study of MAFLD, in general hospitalization, there is no improvement in HB, hemoglobin A1C or glycemic control. But when you compare irregular and regular hospitalization, then HbA1c decrease is a significant factor to improve NAFLD or MAFLD. So how do you think about that?
Thank you very much. Very difficult question. Maybe, unfortunately, this program inappropriate, insufficient for improvement of hemoglobin glycolipid metabolism in MASLD patient. Multivariate analysis identified MASLD as one of poor predictor of hemoglobin A1C decrease. Maybe a longer duration of fatty liver change might affect treatment resistance. So, addition of anti-diabetes drugs, including SGLT2 beta or GLP-1 receptor agonist, should be added to improve cardiovascular disease and glycolipid metabolism, and secondarily improve cardiovascular disease and liver-related event in MASLD treatment resistance patients.
Thank you so much. I agree with you. Maybe SGLT2 inhibitor and GLP-1 agonist can be in future standard drug or treatment in future.
Oda, maybe now phase 3 randomized control trial with GLP-1 receptor agonist is ongoing. So maybe GLP-1 receptor agonist will be launched prior to SGLT2 inhibitor. However, there are different mechanisms of these drugs, and furthermore, there is strong evidence of cardiovascular disease suppression in MASLD complicated by type 2 diabetes mellitus. So maybe this drug might suppress cardiovascular disease and liver-related event in MASLD patient in the future.
Thank you.
Can I just ask one question? It was a very nice talk. I just had a question on currently understanding the very wide benefits of these SGLT2 inhibitors and GLP-1 analogs. So if we get a cirrhosis patient who's having a controlled, well-controlled glycemic with the help of OHAs, would you like to stop and switch the patient to these drugs in a compensated cirrhotic? Or would you like to continue? So that is my question.
Type 2 diabetes mellitus first line treatment metformin. However, metformin is no evidence for improvement of histological finding of MASLD patient complicated by type 2 diabetes mellitus. So maybe order is not important. Order is not important. Maybe monotherapy is better rather than combination therapy. So because side effect is lower level with monotherapy. However, monotherapy lead to resistance case. So we added the other anti-diabetes drugs should be performed.
And for child C patients, which should be the first line agent?
Dysphosphatic?
Child C patients.
HCP patient?
Child C.
Child C patient.
CTPC.
Child C.
Decompensated state.
Decompensated cirrhosis. Thank you very much. コントラインディケーション、
Yeah.
チャイル C。
So which drug? Insulin? Or we can use, because the data suggests that the GLP-1 analogs, because they are not interacting through the liver, can be safely used even in advanced patients with cirrhosis. SGLT2 also we are using now, and we're not having too many problems. Our own clinical experiences that they can be safely used even in patients who are child B or C cirrhotic.
Thank you very much. Unfortunately, there are no answer for your question. So further study should be
the data
performed to
is not-
investigate further child C, including child C patients.
Okay, thank you so much for your question. Any other question? Okay, thank you so much, Dr.
Thank you very much.
Kuchar. Okay, and I'd like to introduce Dr. Giovanni Galari from Italy is joining as a discussant in this session.
Some discussion from audience. It's interesting to go this presentation, but not presentation. So something else. Also in Room, we have a program of it's the same program in some way, but the problem in Italy, I think also in Japan, because I think that this opportunity is to share with a different point of view from Europe and Asia. So in Italy, this program, a kind of this program is not for the patient, is paid from the patient, is a private program, is not paid from Ministry of Health. I think that also in Japan, this could be a problem, because health style modification are not paid from Ministry of Health. In Japan, is the situation in Japan is that of not refundable for the patient. Is a private program.
It's refundable.
Japan is refundable. No, in Italy we have not some program related to MAFLD. But this is a good idea. We have some study in a university to enhance the awareness about MAFLD and lifestyle interventions.
Thank you. Okay, thank you. We are moving to the second topic. The second topic will be presented by Dr. Dan-Yok Yang. Dr. Yang is Associate Professor and Senior Consultant of Division of Gastroenterology and Hepatology at Department of Medicine in National University of Singapore. He will also give us a talk about the prognostic event for MAFLD, CVD, or extrahepatic cancer, and the evidence-based approach for risk stratification. Professor Yang, please.
Thank you, Mr. Chairman. I'd like to register my thanks to the organizers for the kind invitation to participate in this excellent conference, especially in the beautiful city of Kyoto. Even without the cherry blossoms, I think the hospitality has been overwhelming. I'm going to title my talk on the evidence-based approach for risk stratification, highlighting two pieces of work that my students in my university have been working on to understand the relationship between the prognostic event between MAFLD as well as the non-hepatic diseases such as cardiovascular disease and extrahepatic cancers. Some declarations. So we all know that MAFLD, metabolic associated fatty liver disease, is tightly associated with the metabolic syndrome. This has been very generically classified as 3 out of 5 syndromes, be it BMI, overweight, hypertension, hyperlipidemia, triglyceridemia, and diabetes. So the underlying pathophysiology of this is not quite known, but the syndrome has been well described. What is probably not well worked up is the underlying drivers of this condition, which is visceral lipotoxicity, insulin resistance, metabolic inflammation, gut dysbiosis, and metabolic flexibility. So the disease goes beyond just the liver, even though we have lined up the liver in a linear fashion, understanding how it goes from steatosis to steatohepatitis, and finally to cirrhosis and the development of hepatocellular carcinoma. But what is very clear to all of us is that in fatty liver disease, because of its association of metabolic risk, patients are at increased risk of mortality and complications from other organs such as cardiovascular disease, neurological conditions, cancer, diabetes and its complications such as end-stage renal failure, and even what we now know as inflammaging aging conditions such as sarcopenia and dementia are also actively driven by the underlying pathophysiology of metabolic disease. What is the trend of MAFLD and metabolic complications in the world? If you look at this graph from the WHO, which looks at the projected trends of obesity across the world, the dark blue colors represent Northern America and part of Europe. The light blue colors are the people who are in the English-speaking population of what we generally call the West, and Asia are the orange to red color. And you can see that over the next 20, 30 years, Asia will have the overbearing burden of metabolic disease from obesity. And to predict how much of this will convert to mortality, we could glean this from what we have seen from the United States, where look at this population of almost 22,000 deaths in over 10 years. And it showed that in this group, the mortality has increased significantly over the last 10 years, especially among the 65 years old, and also for between 45 to 64. At the young, obviously, we haven't seen a trend. But if this is the harbinger of things to come, Asia is projected to see a sharp rise in mortality and morbidity related to metabolic syndrome. How much does MAFLD contribute to increased mortality? Actually, this is an issue that was actually studied over the last 20 years to really understand does MAFLD really contributes to increased mortality. And the first data that supports this was really from Ray Kim's group, where he looked at the NANES tree study to understand the increase of mortality among patients who had non-alcoholic fatty liver disease diagnosed by ultrasound. And you can see that in overall mortality, actually, it's only a very slight increase in the risk of overall mortality. But if you break this down by the different degree of fibrosis, the mortality becomes significant in the high fibrosis group, where you can see that the hazard ratio goes up to 2.17. And interestingly, in this analysis, he showed that the increased mortality was not really coming from the liver group, although there was a slight increase in hazard ratio for those with high fibrosis score, but it was really driven by cardiovascular disease. And indeed, all the way from intermediate fibrosis onwards and high fibrosis, you can see that the increase in cardiovascular mortality goes up significantly, thus suggesting that cardiovascular disease is probably the single most important contributor of mortality to patients with MAFLD. Interestingly, in this cohort, when he looked at malignancy, he wasn't able to show an increase in mortality from this group of patients, despite them having high fibrosis score, which is perhaps not surprising, as fibrosis is not directly linked to liver cancer or non-liver cancer. In this more recent study that was published by Yunos's group, they looked at the National Vital Statistics Systems, which had about 45,000 mortality, and using their cause of death certificate in patients with MAFLD and other direct cause of death, they interestingly showed that it was the liver-related causes that was the number one cause. 45% had direct liver causes together with MAFLD, and in fact, diseases of the heart was 10.33%, extrahepatic cancer was 6.97%. And a spatter of other conditions, stroke, cerebrovascular diseases was about 1.07%, kidney disease by 0.92%. This anomaly is probably due to the way the cause of death is coded. So if the patients are coded for liver-related diseases and they have NAFLD, it will show up. But if you don't code for NAFLD as a baseline, then you may not. This may explain why in this particular cohort, liver-related death was higher than cardiovascular deaths. But looking further into its other causes, and when you go down to the fine prints, those as less than 1%, we start to see things like hypertension. Of course, some elderly patients might die from pneumonia, influenza. Alzheimer's disease, which we spoke about earlier as part of inflammation, was still low, probably due to the fact that it takes many years before these patients will be at high risk of Alzheimer's disease. But looking at the extrahepatic cancers alone from this group in the US, you can see that liver cancer contributed about 41% of the mortality. And in that group, lung cancer was probably higher than colorectal cancer, 9% compared to 7%. But again, this is probably due to local conditions, especially with other factors such as smoking, etc. So what we wanted to do was to scan the literature to see whether we were able to look at the various contributions from the diseases in patients with NAFLD. So we did this, a group of students in our university did this group analysis called the meta-analysis of meta-analysis. And in fact, there have been more than 45 meta-analyses that have been published related to the MAFLD disease and other associated conditions. And so using this technique of doing a meta-analysis of all those that's been published, we wanted to understand what is the different contribution of other conditions in patients with MAFLD. So after taking out the overlapping meta-analysis and those that didn't quite reach a high level of quality, we settled with about 25 meta-analysis with more than 5.7 million patients. There may have been some overlaps as these patients may be represented across various diseases, but generally 25 meta-analysis. And you could see that the all-cause mortality in MAFLD patients was about 1.34-fold higher compared to people without MAFLD. This was mainly driven by fatal cardiovascular events, 1.3-fold compared to people without MAFLD, and cancer-related mortality just 1.05. So this is all patients, all meta-analysis throughout the world with a slight increased risk for all-cause mortality, primarily cardiac, then followed by cancer. When we look at the hepatic complications, hepatocellular carcinoma obviously was one of the commonest causes. Effect size was 2.39. Gallstone disease, interestingly, is also up 1.55. This has been described in several studies now. But what was pretty surprising was that intrahepatic cholangiocarcinoma was also significantly increased at 2.19. In fact, we do know that in cirrhosis today, you do get intrahepatic cholangiocarcinoma, even though we call it HCC when we diagnose it radiologically. Histologically, you can find that many of these do have cholangiotic factors among them. And in the systemic conditions, of course, diabetes is associated. Obstructive sleep apnea had about 2.22-fold effect size. Diabetes complications such as polyneuropathy, etc., are all upregulated. Interestingly, kidney stones are also the risk is increased 1.73, although the mechanism of this isn't quite well understood at this point in time. And when we look at cardiovascular disease, which is the commonest group of complications, so as a block, there is certainly increase in effect size of cardiovascular disease. But when you look into the various components of cardiovascular disease, clinical coronary artery disease had an increased effect size of 2.18, and the other associated functional cardiovascular disease such as PVCs, prolonged QT interval, heart block was also significantly increased. Hypertension is part of the metabolic syndrome, would understandably be up there as well. In terms of stroke, carotid arteriosclerosis was probably the highest risk when you have 3.20 effect size, and certainly stroke, be it hemorrhagic, ischemic, or heart failure, would also be increased. And in this meta-analysis of multiple 25 meta-analysis, looking at the non-hepatic cancers, you can see that the GI cancers are generally increased with effect size just under 2, and this is already well known related to MAFLD. But thyroid cancer is significantly increased with an effect size of 2.63, something which we do not routinely note or screen for in MAFLD patients, but certainly a significant increase in thyroid cancer on top of the other non-systemic cancers. The next meta-analysis we looked at was really to understand if there is such increased risk of cancer and other systemic conditions, what are the subgroups that we need to pay attention to, which are increased risk of MACE and extrahepatic malignancies. So we undertook a longitudinal cohort analysis of the NAINS cohort with more than 32,000 patients who are overweight and are obese to understand the implications of associated morbidities and mortalities using the MAFLD criteria that APASL has accepted. So from the names cohort of 59,000 patients over 30 years, about 38,000 were overweight and obese, and 32,000 qualified because they had ultrasound done, which allow us to characterize their liver disease, whether it's MAFLD or not, steatotic or not. And this group, what we did then was using MAFLD criteria, subgroup into those groups that just had overweight without metabolic features, which we call the metabolic healthy group, or those that qualified for MAFLD due to their metabolic complications, which we call the metabolic unhealthy group, to try to understand the implications of the metabolic conditions on their diseases. So MH is the metabolic healthy group, which is just purely overweight steatotic, whereas MU are those group with underlying metabolic complications versus the normal. And you can see that in terms of the metabolic unhealthy group, this was the group that had the highest risk of developing complications, be it MACE, or cancers, advanced dying from liver disease such as the clinical significant fibrosis, and cardiovascular mortality and cancer mortality. They were all significant by multivariate analysis for the metabolic unhealthy group. Again, in a metabolically unhealthy group, which had no metabolic complications, so just purely MAFLD by BMI and fatty liver, there was no statistically significant increase in cancer, cardiovascular disease, or in the mortality associated with these conditions. In fact, if you look at MACE, somehow steatosis in overweight patients was protective with an odds ratio of less than 1. And this is surprising, but perhaps gives credence to the hypothesis that actually fat stored in the liver without metabolic disease in a way hides your fat and actually keeps you healthy. But this is something that is probably worth pursuing to understand whether the steatotic liver without metabolic conditions does provide a protective role on top of the condition. So translated to graphs, you can see that all-cause mortality is increased significantly for those with metabolic unhealthy MAFLD. For metabolically healthy MAFLD and non-MAFLD, they come pretty close, although numerically there is a difference. In terms of cardiovascular mortality, you couldn't differentiate those who are with metabolically healthy MAFLD versus those with no MAFLD. Those with unhealthy MAFLD, obviously, is a much higher cardiovascular mortality. And similarly, for cancer mortality, it is those groups that are metabolically unhealthy that registers the high cancer mortality. We then wanted to understand of those metabolic features, which were those that had the highest predictive value in terms of contributing to increased mortality. So what we did was to pull out diabetes as a separate group and compare that to those groups that had more than 2 metabolic risk abnormalities without diabetes. In other words, if you are just hypertension, hyperlipidemia, hypertriglyceridemia, you belong to this group with more than 2 metabolic, if you have more than 2 metabolic risks. But if you have diabetes, you come under the diabetes MAFLD group. And looking at the odds ratio, the effect size, immediately you can see that it is the group with diabetes that contributes to increased mortality. In multivariate analysis, be it MACE, all cancers, cardiovascular mortality, cancer mortality, and all-cause mortality, diabetes was bad news. If you are diabetic MAFLD, your risk goes up significantly. If you have more than 2 metabolic risks, but none of these are diabetes, statistically, we do not see an increased risk of MACE or any of the cardiovascular or cancer mortality, suggesting that there is a direct effect of diabetes as a primary driver, possibly from insulin resistance and contributing to the carcinogenesis. So in summary, the 2 meta-analyses showed that the MAFLD is associated with a myriad of complications and increased risk of mortality through multi-system involvement, which is not a surprise from understanding of the underlying driver and pathology. Patients with MAFLD are at increased risk of liver complications, cardiovascular, and extrahepatic cancer. The risks appeared, certainly in that order, the risks appear to be highest amongst MAFLD patients who are metabolically unhealthy, so those with diabetes or more than 2 metabolic complications, but it is the diabetic group that probably has the highest risk, and therefore understanding these high-risk groups carries significant implications for targeted screening and preventive intervention. I'd just like to acknowledge the Fatty Liver Research Group at university, especially this very talented group of medical students, Kayan, Jieling, Cheng Han, led by Mark and Daniel, who did this analysis. Thank you very much for your attention.
Thank you, Professor Yang, for your comprehensive review. Any questions from the audience? Yes, Professor Yang, as the severity of fibrosis is related to the cardiovascular events. And the previous data also show that the sarcopenia is also related to the cardiovascular event. And if the patient with MAFLD plus sarcopenia may have a greater risk. So during risk stratification, do you think we should also consider the patient whether have the sarcopenia?
Thank you very much for your question. I think you're absolutely right in that patients with high fibrosis probably the fibrosis is a surrogate marker of the long underlying and severe metabolic inflammation that drives cardiovascular disease. And therefore, what is probably not well known today is whether sarcopenia is an effect of the underlying metabolic driver or whether it is an independent risk factor on top of the metabolic risk. I think while it is, as clinicians, we all intuitively know how to treat cardiovascular risk factors, we are less certain about how to treat sarcopenia, aside from just prescribing a diet as well as exercise. And therefore, intuitively, that's something which we have not done well encouraging patients. But certainly, I think now with the big move towards objectively understanding what are the criteria of assessing sarcopenia, testing sarcopenia, and addressing sarcopenia, that will come in very, very important. And in part of our metabolic workup, we will have to look into sarcopenia to see how we can address this and use that as one of the several markers to understand patients who are at highest risk. So I absolutely agree with you that we knew that we need to do that thorough assessment. The challenge in real life is, of course, in our clinics, we are hepatologists looking at liver, the cardiac doctor looks at the heart, nobody looks at overall patients with the sarcopenia. And we are all tuned to addressing obesity rather than patients who are thin. And therefore, that remains one of the clinical gaps.
Thank you. Professor Maiwa.
Yeah, thank you for that excellent talk. I just was the data which you showed for metabolically healthy and unhealthy population with respect to the cardiovascular events was very interesting. I would just like to know in that study, how did you classify a patient with MAFLD as metabolically healthy or unhealthy based on what criteria?
So we use the MAFLD like criteria. So MAFLD, as you know, if you have high BMI, with fatty liver, you could go into MAFLD criteria, or 2, if you've got underlying metabolic diseases. So using that branch, people who are just high BMI with fatty liver is metabolically healthy because they have no evidence of any metabolic manifestation. Whereas people with diabetes, any of the metabolic manifestations, hsCRP, for example, using the MAFLD criteria, would belong to the group with metabolic unhealthy patients. So it's a very empirical division based on the MAFLD.
So in line with the same question, so what did you see? What was the proportion of patients in the diabetes contributing for the metabolically unhealthy population in that cohort?
So in the NACE cohort, diabetes contributed to about almost 50% of the patients. So to be fair, the metabolically unhealthy group was the majority group. It was almost about 90%. The metabolically healthy group was only about 10% of that group, with diabetes being the predominant feature. Yeah, I guess the interesting interpretation about it is that in the comparative field, people have always wondered why the bear, for example, goes into hibernation in winter. They store a lot of fat in the liver, but they don't get inflammation and they don't get increased metabolic risk. So it's always hypothesis that storage of fat in your liver without inflammation actually protects you and hides away the fat from a coronary artery disease, which perhaps may answer why they have lower cardiovascular risk. But that's a very just interesting fact that we have not unraveled yet.
Okay. Any more questions from the audience? Okay, if there's no question, we'll move to the next talk.
Thank you.
Okay. Thank you, Dr. Yang.
So the last speaker in this session is Dr. Lucky Maiwal. She is a professor in Department of Hepatology, Institute of Liver and Biliary Sciences, ILBS, in India. So please start the lecture.
Thank you. And almost a similar topic has been given to me. So I'll be also discussing about the prognostic event for MAFLD, the cardiovascular disease or extrahepatic cancers, but I'll try and bring up the concepts and the evidence based on this. So a lot of things may overlap with the previous speaker, and I'll try to skip most of it. So this is going to be the outline of my talk. So when we talk about metabolic associated fatty liver disease is when we're talking that the patient has hepatic steatosis which is detected by either of the imaging techniques and has overweight or is lean or normal weight with the presence of 2 metabolic risk abnormalities or has type 2 diabetes. So again, like the previous speaker had signified, and diabetes prevalence in the MAFLD population is associated with higher risk of cardiovascular disease as well as cancers. And again, the metabolic status, which was again a very important thing and has to be analyzed, is to understand of all the patients which we see for MAFLD, which is the population which is metabolically unhealthy, which is clearly defined by people who have visceral fat more than the subcutaneous fat. They have higher levels of ectopic fat location accumulation, specifically in organs like liver, and they get to have non-alcoholic steatohepatitis. And these are the patients who are metabolically unhealthy, also have sarcopenia or decreased muscle mass, poor fitness, insulin resistance, and a higher cardiovascular risk. As against, so this set of patients is very different from a patient who's obese but metabolically healthy. And this is a patient where the subcutaneous fat may be more than the visceral fat, and they have no other complications, which I mentioned for the metabolically unhealthy group. Now, when you look at the association and the prevalence of coronary artery disease or cardiovascular disease in patients with MAFLD, the figures are alarming, and it varies from 31% to as high as 62% from the United States of America. So again, signifying the close association of these two entities. And we also know that it is not just the cardiovascular disease, and we saw data of the association of the different other diseases. And therefore, when you're dealing with a NAFLD patient, it is very important that we just not assess the liver. It is important to assess the metabolic status of the patient, the accumulation, the predominance of fat accumulation, and also look for all these associated systemic conditions, because if they are missed, they may have an impact on the prognosis and the management of these patients. Now, there are shared risk factors. So why we are saying that they are associated, because when you look at the cardiovascular disease in isolation and NAFLD population, you know that there are shared risk factors, and that is why the association is there. And what is the pathophysiologic basis? So we know in the fatty liver patients, there is adipose tissue dysfunction, which causes an increased flux of the long chain fatty acids, glycerol, and the pro-inflammatory cytokines to the liver. And there is an increase in the hepatic lipogenesis. There is hepatic insulin resistance, increased export through the VLDL, causing increase in the VLDL synthesis. And again, there is a blockage of the transformation acetyl coenzyme A to the oxaloacetate pathway, and there is increased hepatic glucose output, which is seen as prevalence of the hyperglycemia in these patients. And how do we link the fatty liver related pathophysiologic mechanisms with the vasculature? So what happens in these fatty liver patients, the same mechanisms which are there, and apart from the influence of hepatokines like FETUin A have been shown, and plasminogen activator inhibitor levels over here, there is vascular endothelial disruption, and there is an increase, there is a low-grade inflammation, there is the monocytes and the macrophage population gets attracted to these sites, and they cause the development of these vascular plaques. And with an acute thrombotic event are therefore very common, and so is the association with the cardiovascular diseases. The genetics is also something which should not be forgotten while we are seeing these patients, because it is not just the environmental factors, but the genetics. And when you see, look at the 3 common genes which have been shown to be associated with fatty liver disease, the PNPLA3, the TM6SF2, and the glucose kinase receptor. So the GCKR gene is something which has shown to have a very high association with increased triacylglycerol, the LDL cholesterol, and the type 2 diabetes in patients with MAFLD, and these are clearly higher risk factors for the development of cardiovascular disease. So we are very clear that there is a bidirectional association. We do not know what comes. The patient may manifest a cardiovascular event first in the natural history, or may come to us with MAFLD and get a cardiovascular event. Now, what is the spectrum of cardiovascular diseases? Again, nicely shown by the data, and we know that there is a large spectrum and you see different sets. And what is more important, particularly in context, is to look at the associations vary from moderate to strong evidence. And there are a lot of meta-analysis which have summarized showing a clear association of MAFLD with the cardiovascular diseases, particularly coronary artery disease. There are studies looking at the heart failure with low or a preserved ejection fraction, atrial fibrillation, strokes, and so on and so forth. The heart failure with preserved ejection fraction is also something which is very interesting. And there are three phenotypes which could be very relevant when we're dealing MAFLD patients with cirrhosis. So there can be an obstructive phenotype, which is actually caused by the increase in the resistance to the transhepatic blood flow caused by the increased sinusoidal resistance and the high portal pressures. The metabolically, the high heart failure, which with the preserved ejection phenotype is determined by is driven by severe systemic inflammation or endothelial dysfunction and visceral obesity, which is seen in these patients. And then there is an advanced liver fibrosis phenotype where a hyperdynamic circulatory state drives the heart failure with preserved. So this is something very interesting and can be looked more carefully of what is guiding the development of this heart failure phenotype in your set of patients. Now, when you look at the, again, studies over here with meta-analysis, cross-section, longitudinal data, we see that the odds ratio for the development of the particular phenotype for the heart failure is seen in almost varying from 1.6 to 2% of the population times higher risk or odds of getting the cardiovascular events. Now, the next important the event is the diabetes association. And like we already know that with increase, and this was a study which was done in histological proven NASH patients. And again, it showed that with increase in the fibrosis, there was an increase noted in the prevalence of diabetes. And again, a very nice large cohort study of 13,000 South Korean patients who were non-diabetic and followed up with the ultrasonography to look at how the diabetes can also incidentally develop in patients with MAFLD who had no diabetes at onset. And this was seen to correlate with the progression of the disease. So if the disease was progressing from a moderate to severe MAFLD, so what we say is that we need to explore the hepatogenous diabetes. What are we seeing in these patients? It is the diabetes driven by MAFLD, or it is a different phenotype of diabetes or hyperglycemia that is seen in these patients. Now, when you look at the extrahepatic cancers, again, the mechanisms we know which are driven in patients with MAFLD, there is insulin resistance, there is decrease in the adiponectin, and increase in the inflammatory mediators. And apart from that, the gut dysbiosis and the bile acid signaling pathways are something which are important and interesting. Now, this is a large meta-analysis which had looked at all sorts of extrahepatic cancers, and it was seen that there was a very close association of all phenotypes, starting from esophagus, stomach, GI cancers, pancreatic, thyroid, lung cancer. So all different extrahepatic cancers were seen to be associated with MAFLD. And when you use different definitions, what does this have an impact? So this was a meta-analysis again, which looked at that there was a higher incidence of colonic adenomas, which were picked up using the MAFLD definition. But overall, the data suggests that whether you use the revised definition or the older definition, the association with the risk of malignancy almost looks similar. With hepatocellular cancer, we know that HCC also has a common association with MAFLD, and we're seeing the de novo development of HCC even in the absence of cirrhosis, and that is more and more recognized as a non-cirrhotic patients with NASH getting HCC, and which needs to be screened, but we still do not have any surveillance protocols of what are the risk factors where they should be subjected to routine surveillance in these patients. Cholangiocarcinoma is another malignancy which has shown a very close association. The studies over here are mostly cross-sectional, and the meta-analysis of these cross-sectional studies has suggested an association. So when we look at the pragmatic approach to the assessment and management of cardiovascular diseases in patients with MAFLD, it is important that we assess the patient in a holistic view. We look at the glycemic control, we look at the risk factors for cardiovascular disease, assess all the comorbid and at the risk of atherogenic dyslipidemia, give a score to the patient. and then assess whether the patient qualifies to have diabetes, CKD, hypertension, to have any of the drugs which have been shown by the previous speakers to be of very benefit and should be started as the first-line therapy in these patients. Also, if the risk is high, consider adding low-dose aspirin or even statins to these patients. And when the risk of, with the scoring system, your patient is having a high risk of a coronary artery disease, it is better to go with the calcium artery scoring system and screen the patient for an occult cardiovascular disease. So this is how the pipeline and the disease state is moving. We're now targeting not just fatty liver, but other components and diseases which are associated with the metabolic derangement in these patients. So overall improvement of the metabolic health is the key to improve not only the liver, but all the other organs that are involved in these cases. So I would like to summarize by saying that change in the nomenclature shows concordance between the new and the old definitions. The MAFLD or MASLD, what we want to say, is a multi-system disease and is an independent risk factor for cardiovascular diseases as well as the risk of liver and extrahepatic malignancies. The surveillance protocols have to be more protocolized for the non-cirrhotic and we need to identify those high-risk groups with fatty liver who are predisposed to get and should be screened for the development of these malignancies. Thank you.
Thank you, Dr. Maiwa. Very great lecture. So any comments or questions from the floor? So I have a question. You mentioned the genetic factors such as PLC or TM6, SF2. So is there any association between such genetic factors and CVD risk? So does a patient with the PNPLC morphosis?
Amongst all the genetic factors, we know that PNPLA is associated with dysregulation of the lipid accumulation and the VLDL transport out from the hepatocytes. But what has been recognized in the context of cardiovascular disease, the GCKR was the more important gene which was actually governing the cardiovascular event development in this population. But again, the data is not that strong to say that this is the gene, but the genes also, the genetic makeup of the patient is also a driver for how the patient behaves and how it responds to the different modalities and the risk of other complications. So we still do not have, but yes, we are moving to a field where we will be going towards more like precision medicine, where we'll be checking the genetics and looking at all the factors which are influencing the patient and the disease phenotype.
Thank you. Oh, please.
Thank you very much for a great talk. You, in a previous talk, you asked a question about the insulin versus the SGLT and the GLP treatment. In your center, do you take patients off who are stable on insulin and put them onto those?
Yeah. So currently the endocrinologists and everybody has reached to a consensus that if you have risk factors of cardiovascular disease, a cirrhotic patient, you also achieve ascites mobilization and you can cut down on the diuretics, which is again a problem, and rather giving SGLT2 can improve the renal and the cardiovascular health. So we are also conducting studies on that. So there are different aspects of SGLT2 which can be beneficial in these patients. And therefore, we consider, obviously, in the child B and child C patients, the OHAs are something which can cause wider fluctuations in blood glucose, and we usually consider stopping them. For compensated cirrhosis patients, if they are highly obese or morbidly obese, we do consider switching them to a GLP-1 analog.
Thank you. So any comments or questions? Please.
Thank you. I'm Imelda from Indonesia. So I want to ask, when you switch the patients in cirrhotic patients from SGLT2 or from DPP4 to insulin, I mean, for a long time, we know that we should give insulin to cirrhotic patients. Thank you.
So that is why the field is changing. And we are no more considering insulin should be the first line drug in patients with decompensated. And that's why I was sharing this experience. And this is our own experience from our center and also from other centers in India, where people are practicing. And we have discussed in different forums with the endocrinologist that this is a better strategy now to treat these patients, because with insulin, you're not doing anything else to the other organs which are also involved in these patients. So to improve the overall health, the SGLT2 inhibitors, again, in child C, the safety is not established, but GLP-1 analogs can be safely used.
Okay, thank you so much for the great lecture.
So, okay, we can still have time. Then can we have short discussion? It's okay. Then please come to on the stage, the speakers. Just 10 minutes around. So, and here we try to have open discussion. If you still, the audience still have any questions, then please, stand by the mic. Okay, so I have a question. So today we talk we discuss about CVD risk and extrahepatic cancer risk. So when we think about its opposite and in Asian conditions, so how can we deal these risks? So do we have to think CVD risks, especially CVD risk in Asian people as well? So that's my first question, if it's okay. So I'd like to hear your answers.
Thank you very much. In Japan, CETA score is one of CVD risk score composed of age, gender, blood pressure, and familial history of CVDs. CVD CETA score is useful for detection of CVD risk scores. And the result of CETA score correlate with those of Flamingo score. Furthermore, recently in Japan, Hisayama score is more precise test for CVD risk score than CETA score. Maybe okay. In Japan, the mortality rates are low level. However, incidence rates high level CVDs. The reason maybe interventional radiology for CVDs is advanced. Furthermore, hypertension and type 2 diabetes mellitus are well controlled. With Japanese medical insurance, and extrahepatic malignancies are picked up early with general health check. Mortality rates are not high rate. Incidence rates are high rate.
So just to add that, ideally, I think EASL has been leading this to push for a metabolic clinic rather than just a fatty liver cardiology or endocrine clinic, where we assess the patient holistically. And ideally, if you have got high risk factors in diabetes, fatty liver, then you should be screened for cardiovascular health as well. I think from practical perspective, in Singapore at least, we use statin with very low threshold. If they have fatty liver and we have very low threshold of starting statin, at least to protect cardiovascular diseases, there has been some call for very high risk patients, if you can assess the metabolic risk, HSCRP and so on, family history, to even consider doing CT coronary angiogram for screening, but that has not passed the validation whether it's cost effective or not. But I think over the next few years, there will be more efforts to study strategies to identify these patients who are highest risk so that we can give a directed prevention and intervention.
So again, I would say that for your set of Asian patients and our set of patients where viral hepatitis is the predominant etiology, which carries a higher HCC risk. So again, natural history studies were very intriguing because it has been shown that in natural history studies that if you have metabolic syndrome with a viral hepatitis, actually some studies have also shown that your risk for the disease progression is lowered and the risk of cancer development is lowered. So that is also something which has to be with the newer definitions that can be easily assessed in natural history long-term studies, which can give answers to the risk factors which are associated, and especially in the Asian population where we see a predominance of the viral etiology.
Okay, thank you. Then you present the data about GCKR gene. It's the SNP can be a risk of CVD disease. So, but I think the metabolism paper, but that kind of study can have some selection bias, like PNPL3 can be a negative risk of CVD disease, but the kind of study
show that it is negative risk. They showed the highest risk when they studied these 3 genes was associated with the GCKR. They did not show that PNPLA has less risk, and they were only evaluating with respect to diabetes, LDL cholesterol, and the triacylglycerol accumulation in the liver. So that was the 3 factors which they had assessed.
Okay, thank you.
Important thing is the measuring the LDL cholesterol and targeting the LDL cholesterol in patients with fatty liver, because we're looking at triglycerides, but this is something, a measure of the atherogenic and the vascular thrombotic risk profile, and should be specifically in cardiovascular disease prevention where the risk factors are high. LDL cholesterol should also be targeted below 70.
Okay, thank you.
Another topic, I have a question mainly to Dr. Akhtar. So, how do you determine the target of hospitalization therapy in MAFLD patients? So, who is the target of the hospitalization? How do you determine?
Fatty liver patients, all patients.
All patients.
Yeah. Maybe mild fibrosis, fatty liver change with mild fibrosis, CVD risk patients. However, fatty liver change with severe fibrosis stage, liver related event. So all patients advocate all patients suitable patients. I think that.
Thank you so much. Another comment from others?
Perhaps if I ask a question, for the hospitalized patient, what is the program do you do for them? Do you see a multidisciplinary team, dietitian, physiotherapy? What is the package when they come to the hospital?
Our program, 6 days hospitalization program, from Monday to Saturday hospitalization program. Aerobic exercise, 4 to 5 minutes, 20 minutes. And aerobics resistance exercise, 4 to 5 minutes, for 20 minutes. And that diet, 30 kilocalorie multiplied by ideal body weight, daily intake. So personalized diet and exercise treatment program. Furthermore, we guide regular and repeated hospitalization program every 6 months. This program helps to sustain patient motivation for lifestyle intervention. Recently, we reported at 2 years after the start of treatment, liver function test with regular and repeated hospitalization program every 6 months more effective than irregular hospitalization or and no hospitalization patients.
Okay, any other question? Then maybe my last question is, so for the patient with decompensated fatty liver disease or MASH or NASH patient, so with diabetes, so what is your purpose of glycemic control or your treatment? So that's my curious point. So when you use SGLT2 or GLP-1 for decompensated patients, so what is the purpose? So that's my last question. So
very difficult question. The compensation cirrhosis should be performed. Best choice, transplantation. Best treatment, I think that. And GLP-1 receptor agonist and SGLT inhibitor is contraindication for decompensated cirrhosis. So transplantation best treatment, I think that.
and you don't use SGLT2 or GLP and GLP-1 for decompensated.
So we're talking about the decompensated group because there, if your HbA1c, which is not reliable and could be falsely low, and if the patient has high HbA1c levels and you're wanting to correct the glycemia because it is important, the risk of infections and other complications are associated with the blood sugar levels. So awaiting liver transplant, what strategy can we use as a drug therapy, medical treatment? Obviously, insulin will be there in most of these patients, but it is now coming up that because of the benefits of these drugs, it is better to consider in the selected cohort wherever it's possible to give. SGLT2, we do not give in the extremely sick or deeply jaundiced or very sick patients, but yes, child B and early child C patients can obviously, in a selected cohort, we can obviously use the benefits of these drugs in dealing with the other associated complications and comorbid diseases.
Okay, thank you.
Maybe just to add that, so I agree that liver transplantation would be ideal. I think we want to be clear that for the treatment of the cirrhosis, none of these drugs has any benefit at this point in time. In fact, there is some concern that GLP-1 in the decompensated cirrhotics will cause them to lose more weight, develop sarcopenia, and have worse liver outcomes. So there's one class of drug you might want to avoid in the decompensated cirrhotics, although the companies are doing a lot of studies to try to understand that the effect of that side effect. But for diabetes itself, then as discussed, insulin would help. SGLT, if you can get away with patients who are not too sick, would be ideal. But the answer has to be probably liver transplantation.
Okay, yeah, I agree with you. So because the sarcopenia is the risk even after liver transplantation mortality, and also obesity is also risk of mortality after liver transplantation. So that's really an annoying question, but yeah, as you say, so we can have treatment, the individualized treatment, as you said. So yeah, I agree with you.
I totally agree, and this is a very important point that with the message should not go that GLP-1 analogs should be used, because if you're cutting down on the nutrition and if the patient starts losing appetite, you may cause more problems rather than doing benefit. So where a low dose of you can achieve the metabolic control, and you may not target a very high dose again to target the weight reduction in that set of patients is very important. Nutrition is the primary thing, which should not be compromised.
Okay, so any other question? Okay, thank you so much for your great presentation and discussion. And thank you for joining this session. Thank you so much.